Good afternoon, ladies and gentlemen. Welcome to our Digital Pathology Seminar at the 112th USCAP annual meeting. My name is Jean-François Pomerol. I'm the co-founder and CEO of Tribune Health. For those who are not familiar with Tribune Health, our company offers AI-powered digital pathology and telepathology solutions. We have been developing informatics solution for pathology labs since our creation 15 years ago. And we are headquartered in Paris with a subsidiary in Canada, one in US, and we have now a customer in Europe and in North America. Our team is very proud and excited to be part of this digital revolution, both in diagnostic and drug discovery. And we strive continuously to innovate and to provide solutions to support the work of pathologists and to improve the patient outcomes. Our image management solution, called Calopix, has been awarded in 2023 for the second year in a row, best-in-class solution for digital pathology, demonstrating its value for customers. And let me introduce you to Marie Brevet, Dr. Marie Brevet. As a pathologist, Dr. Marie Brevet started her training in Amiens, in France, then moved to Japan and spent time at the Memorial Sloan Kettering Cancer Center in New York. As a professor at the Lyon University Hospital in France, she led research projects and held managerial positions for over 10 years. In 2020, she joined the private lab group Cypath, the second largest French private pathology lab group and a key player in medical innovation in France. Passionate and convinced that medical research benefits from public and private partnerships, and relying on the expertise of the Cypath group, Dr. Brevet created Cypath RB in early 2021, which is the first private research structure dedicated to histology and cytology in France. Thanks to her medical knowledge and her scientific mind, she now plays an important role in the development of digital pathology and artificial intelligence algorithm within the Cypath group. Her public and private background will help the integration of this innovation in the medical practice. Her public and private experience will clearly be an asset to meet the next challenges of integrating them into the medical care of patients. Today, Dr. Brevet will be sharing her first-hand experience regarding the optimization of pathologist workflow through the utilization of digital pathology and AI algorithm. Dr. Brevet, the floor is yours. Thank you very much.
Okay, thanks. Thank you, Jean-François, and thank you to give me the opportunity to present you the Cypath group and how we decided to move to digital pathology. So in a few slides, I will present you the Cypath group when we will discuss why we decided to move to digital pathology, and in the last part of my presentation, I will explain you how we do that. So the Cypath group is the second largest independent group in France. We are only pathologists, so 100% of the doctors are pathologists. We are located in the east of France, in the east part of France, with 9 technical laboratories. We analyze more than 800,000 cases per year, more are histopathology, and we are working with public hospitals, but most of our partners are clinics. Of course, we have a technical expertise for histopathology, cytopathology, immunohistochemistry, and we also have a molecular platform with the NGS capture for DNA RNA-seq. Some of our pathologists in the group are implicated in the French National Expertise Networks, as for lymphoma and sarcoma, for example. Some pathologists are specialized in dermatopathology. Other pathologists are experts in molecular pathology. And several of us are implicated in the national and scientific societies. So for histopathology, notre workflow is this one. On each Cypath location, on each Cypath site, we have centralized production for HE staining or HES and routine immunohistochemistry. And only in Lyon, we have the molecular platform, and we have some specific immunostaining, for rare antibodies or antibodies that we don't use for for routine practice. And the pathologist could analyze the slides by a microscope for the moment, connected to the laboratory management system. So in the group, the headquarters is in Lyon, in the center of the group. And as I explained you, the molecular platform is only in Lyon, and the experts for lymphoma, sarcoma are located in Lyon too. So for the moment, when the other cities out of Lyon wants to have specific immunostaining or molecular techniques, they send the block by car or by post-mail, depending on the location. And the blocks paraffin arrived in Lyon, and the technique is performed in Lyon. And then the blocks paraffin and the slides go back to the different places out of Lyon by car or by post-mail. So why we decided to move to digital pathology? This slide is exactly the same one as previous, but just to, you can imagine that with digital pathology, we can imagine that the paraffin blocks travel to Lyon for molecular techniques, expertise, or specific immunostaining. But after, we can imagine that the block stay in Lyon and can be stored in one unique place, and only the digital slides represented here by the curved line are travel from Lyon to the other location. And in the future, probably in the next 10, 15 years or 20 years, we will have only one big laboratory. And in the different place in France, the pathologists only do, and technicians only do gross examination and paraffin blocks production. And after, all the paraffin blocks travel to one big lab, probably not in Lyon, because Lyon is too crowded and expensive, but maybe somewhere in the landscape. And in this one big lab, we have all the scanner, all the immunostainer, the molecular platform, and there, after the techniques on this one big lab, there is only one storage place. And we can imagine that the digital slides travel to the pathologist. The pathologist could be in the lab, or could be at home, or could be abroad, why not? So that's this data coming from a French investigation from last year. And for the moment in France, only 20–25% of the lab use full digital pathology for third diagnosis. And the main difficulties are lack of financial support, lack of informatic structure, lack of time, medical and non-medical staff. Because the lack of pathologists in the reality in France, with this French investigation, we can see that more than 25% of pathologists have minimum 60 years in France. And specifically in public hospital, 50% of laboratories have at minimum one position available now in France. So we need to attract the young pathologists. We need to have a non-medical staff, and maybe digital pathology and artificial intelligence algorithm could be a part of the solution. So organization, lack of pathologists, and the third reason why we decided to move to digital pathology is because I'm convinced that computational pathology is the next revolution of our specialty. Some artificial intelligence algorithms are already approved in oncology by FDA or by European laws. And in this algorithm, the first place is for radiology, but pathology is in the second position. And if we look at which organ are concerned, breast cancer is the first organ, then lung and prostate. Just to give you some example of artificial intelligence algorithms that we will use in the future. So this example is, the first one is, for example, cancer detection. And these algorithms could give you the tumor tissue percentage, the size of the tumor, give you the grade, and can create a report you just have to integrate in your histopathological report. Another group of algorithms are the immunohistochemistry quantification. Here an example for HER2, but you have similar algorithms for Ki67, estrogen receptor, etc. Another group is molecular prediction. Here a French study from Institut Curie who predict HRD status in breast cancer, but you have similar data for MSCI in colon cancer or BRCA, etc. And a last example, it's clinical prediction, which is an algorithm that could predict which patient will benefit from chemotherapy after breast cancer surgery. And what is interesting in this algorithm is that it can be in place of molecular signature now with brain cancer. So you know that molecular signature are time-consuming, material-consuming, are cost expensive, while these algorithms, you could have the results very quickly, just on HE staining, and you have a report that you can integrate in your histopathological report exactly as a molecular signature. So now we decided to move to digital pathology, and how we do that. As I explained you, we are a private lab. We don't have any public financial support, so we have to create the money that we use for digital pathology transition. And in the Cypath group, so you have the pathology laboratory, the very big team, and we have the Cypath RB, the new research and platform society that we created 2 years ago. And we have 3 axes: clinical research, biological resource centers, and the third axis, the most interesting in my point of view, is, of course, digital pathology and artificial intelligence algorithm. So the clinical research, very quickly, it's activity that already exists before the creation of Cypath RB, probably in the same in your lab, where we provide some paraffin blocks and slides to permit the inclusion of patients in clinical trials. And sometimes before we did that for free or for a few euros, and I spent a lot of time the first year of Cypath RB to meet all the clinical research unit of our clinics partners and to negotiate and to reevaluate the fees we can obtain for this activity. The second axis is the biological resource center. It's a new activity in the Cypath group. We obtained the ministerial authorization, organize everything to inform the patient, and now we are able to take benefit from the biological resources. It could be physical samples, digital slides, or annotation. And the last axis is digital pathology and artificial intelligence algorithm co-development. And with Cypath RB, we increased the financial profit of the Cypath group the last 2 years, and it partially supports the digital pathology transition. So at the beginning of the 2021 year, Philippe Chalabres, the president of the Cypath group, decided to move to digital pathology. And the first 3 questions were which image management system, which infrastructure, and which scanner. And these 3 important questions are interdependent. You can not ask a question and after the second and after the third. You have to think about the 3 questions at the same time. So that's the workflow now, and that's the workflow we plan to have with digital pathology. So of course, molecular pathology, we will still analyze the data with laboratory management system, but for all the technical laboratories, when we produce slides, we plan to digitalize the slide with the whole slide scanner, send the slides to the image management system, and the pathologist will analyze the slides via viewer. So in July 2021, Philippe Chalabres signed the contract with Tribune Health, and it was the beginning of the project. So very quickly, the viewer Calopics, you can see the different cases. You can see if the case is urgent or not. Of course, you have name of patient, the organ, which pathologist is responsible of the case. You can see all the slides, and when you click on a slide, you can see the slide, do annotation, etc. The second question was infrastructure. And for that, your IT manager is your best friend. Because you can have a very nice technology, but if the infrastructure is not good, the project will not succeed. So before we begin the digital pathology project, the infrastructure was this one. All the laboratories are interconnected together around the database, the laboratory management system. In the first year, the IT manager organized the storage for the server for the Tribune Health viewer, and storage for the storage for the slides, for routine slides and research slides. We have a scanner with a server, and we upgraded the medical desk, so the screen and the computer for all pathologists in the group. The next step was to duplicate the computer links to increase the internet debits and internet access to permit the digital slides to travel between different places of the Cypath group. And at the end of the project, when we will be in full digital pathology, we plan to have scanner on each technical lab, and the slides will be stored on each technical lab. Because for the moment, for example, in city number 5, most of the slides analyzed by the pathologists are produced by the city number 5. But maybe in the future, one big lab, the slides will move between the different pathologists and the different places of the Cypath group. Which scanner now? When we think about the scanner, you have to know exactly how many slides you produce every day. And with that, you will decide the capacity of the scanner, which speed you need, which objective do you want. If you do cytology, probably you will need the Z-stack option. If you do fluorescence, if you have mega slides, it's all these questions you have to have the answer before you choose the scanner. And be careful with some small details, but it's not very small detail. For example, size of the digital slides could change scanner to another. Here, it's only biopsy slide on these tables. That's why the size is not too high. But for example, for the slide number 5, with the scanner number 1 is 0.15 gigaoctet, while in the scanner number 3 is 0.46 gigaoctet. So if all your storage capacity is organized with the scanner number 1, and after you decided to buy a scanner number 3, you have to upgrade your storage. So that's why the first 3 questions are interdependent, and you have to think about everything before to completely block the answer. This table is just, the problem is not completely solved, but now we are thinking about how we will organize the park of scanner for all the group. Because we are a multi-seat group, we decided to divide the group in 4 subgroups. And for each group, we define which city will be the backup for the other. So, for example, in Lyon, it's a very big city. We need a backup in the lab. But for the group C, for example, we have 5 cities in the group C, so only 1 city will have an overcapacity of digital slide to be the backup of the other in case we have a problem with the scanner of a city. And of course, for each location, we know exactly which lab have mega slides, which lab have fluorescence, and we can organize the park of the scanner with that and to show the best scanner supplier in front of what we need as capacity and options. Medical equipments now, I think it's the easiest part. You just have to ask your pathologist, 2 or 3 pathologists, to test different screens, to test different mouse. You have to upgrade the computer to be sure that you can move on the digital pathology very quickly from the lab at home with VPN connection, etc. So it's not so difficult. Just take time to do that. And the technical adaptation now, that we are in this step now in our group in Lyon, and I think it's small details, but small details could be very important for the digital workflow. For example, sometimes when we don't have the medical staff to cut and stain the slide in the lab in Lyon, we send the blocks to other cities of the groups to be cut and stained in the other city, and after the slides go back to Lyon to be analyzed by the pathologist. And when the technician digitalizes this tray of slides, I can see some slides on the IMS and the top line, and the bottom line, I cannot see the slide on the IMS. So I just take a picture with my iPhone and I say, okay, not okay, and I send this picture to the technicians, why I can see this one and why I cannot see this one slide. And the technician looked what was the problem, and the problem was the barcode. Because in the top, the barcode is small and is well recognized by the scanner. But at the bottom, the barcode is a little bigger, and it was not recognized by the scanner. It's just a very small detail, and this detail is not a problem for the workflow now, but for digital workflow, it's a big problem, because at the end, you cannot see the slide in the IMS. So it's small data you have to find the solution to permit the workflow. So now in Lyon, we are 2 pathologists using digital pathology every day for our activity, only 20% of our activity. What about artificial intelligence algorithms now? As I explained you, Cypath RB plans to do a digital slide supplier to perform co-development and validation of the algorithms before the integration of this algorithm is a routine workflow. And we had a poster this morning about one validation study we performed in Cypath RB, and we evaluate 4 different algorithms to see which one could be the better for HER2 scoring, or focus on HER2 low. So that's what I plan to do with Cypath RB. And at the time, we will decide which algorithm is the best one. What I imagine in the future is that all these artificial intelligence algorithms will be connected, integrated with the Tribune Health IMS, and that we don't just have to click on the button. For example, here we have a HER2 slide. We can imagine that we will have a button on the viewer. We just have to click on the button, and we have the data about the HER2 algorithm results. And for example, here we can select a prostate biopsy, select 1, 2, 3 cases of prostate biopsy, launch the algorithm, and when the pathologist opens the case, all the data are already presented by the algorithm. And in the perfect future, we can imagine that the algorithm is automatically launched depending of the barcode of the slides or something like that. And when the pathologist opens the viewer, all the prostate biopsy cases are already analyzed, all the HCR2 immunohistochemistry are already analyzed, etc. And you don't have to push on the button anymore. It will be very nice. So the pathological report in the future will integrate, of course, gross examination, probably a few lines of histopathological results, immunohistochemistry, molecular data, and also the artificial intelligence algorithm, diagnostic algorithm, and prediction algorithm. I thank you for your attention, and I would like to thank all the digital pathology project team. Thank you.